Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. Today, we're going to be talking about clinical reasoning. I've been focusing on clinical reasoning a lot. I've talked about it in the past, but I'm sort of focusing on it now. What that means is you're getting questions that you may not necessarily know the answer to. When you don't know the answer to a question, you have to use clinical reasoning and think your way through it. You cannot memorize everything you have to know to pass NCLEX, so you have to use good clinical reasoning. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek is the GOAT of NCLEX preparation. Clinic Reviews is primarily an NCLEX preparation organization, and we do offer services. We provide this YouTube to you free of charge so that you can trust us. You know what we're doing, you know what we're talking about, so that if you come to our web page, clinicreviews.com, and purchase one of our products, you know that it's going to be a quality product. And it is. Mark Klimek is phenomenal. He's been doing NCLEX prep for over 40 years, and he's just really great. So you can do the online on-demand 21 plus hours of NCLEX prep. You get it for, I think, 3 months. You pay a certain price, $400. You get it for 3 months. Every once in a while, they'll have like Black Friday, they have a coupon, and a couple other times of the year. And we also do a streaming service. The streaming service is where you can find all of the videos that we have on YouTube, as well as some more. I've recently deleted a lot of the year one videos. They are all on the streaming service. You can find them there. And we also have Zoom small group tutoring. So if you want to meet me live over Zoom, you can sign up for our small group tutoring over Zoom. That's where I do next gen tutoring. So let's go ahead and get started. We're going to use musculoskeletal as the topic to talk about how to use clinical reasoning. So remember, there are things you have to have memorized, obviously, but you cannot memorize everything. So I want to show you how to answer questions if you don't necessarily automatically know the answer to them. And what happens when you use clinical reasoning, you think in general, what do I know about this topic? And then you try to pick answers that are consistent with what you know. Mark Klimek always says, you never answer questions based on your ignorance. You always answer questions based on your knowledge. So don't let your ignorance throw off what you do know. A 72-year-old woman with osteoporosis reports new onset of severe back pain after bending over to pick up a magazine. Which intervention should the nurse implement first? Encourage bed rest and maintain supine position. Administer the prescribed opioid analgesic, apply a heat pack to the lumbar area, assist the client to log roll when repositioning. All right, osteoporosis is loss of bone. And if she has osteoporosis and she has severe back pain after bending over, something happened to her back, right? Something we can't really know, and you're not expected to necessarily know, but something happened to her back. And so when you think about this, if you're like, I don't know what happened to her back and how am I supposed to know what to do, you should think generally as it relates to back injuries. Like, what do we do when someone has a back injury, right? So the key thing is, there's multiple things, but one of the key things is we want to keep the spine straight. We want to maintain a straight spine when they're moving around and so forth. So let's look at our answers. Encourage bed rest and maintain supine position. So I like the supine position because that keeps them flat. I don't know if they have to be on bed rest, but we'll keep A as a possibility. Administer the prescribed opioid analgesic. Yeah, I mean, I like that. I don't know. I don't know if I would do that first, but definitely that's a problem. So they have back pain. Apply heat pack to the lumbar area, maybe. It doesn't say lumbar back pain. So lumbar is the low back. I'm not crazy. I mean, you could apply heat, that's fine, but I'm not sure it's the lumbar area that's hurting. So I'm not crazy about C. Assist the client to log roll when repositioning. So log rolling, so I'm just going to tell you this. This is a testing strategy, but log rolling is the best answer on NCLEX as it relates to back injury. I don't know why. It's always the best answer. But because log rolling shows that you know you have to keep the spine straight. Bed rest and supine position does not necessarily show that you know you have to keep the spine straight. And she may or may not need an opioid analgesic if we can keep her spine straight, because the pain may be reduced just by keeping that spine straight. So I'm going to have to pick D. And I'm telling you, I don't have like a super good reason why this is the best answer, other than, I know it's a first question, but sometimes the first and best end up being the same thing, same answer. For some reason, log rolling your patient is like the ace of spades when it comes to back injury. Okay. So I would just remember that. Now, if it's totally inappropriate, don't pick it. Don't go, well, Sharon said to. No, there has to be a reason why you'd pick it. But like if something totally unrelated, like don't pick it. But as it relates to back injury, log rolling is like almost always the right answer. A patient with acute gout has been started on allopurinol. Okay, so gout is caused by uric acid sediment settling in usually the toe area, causing pain and swelling. It's a type of gout. I'm sorry, it's a type of arthritis. The nurse should teach the patient to do what? Avoid foods high in vitamin C, increase food intake to at least 2 liters a day, limit dairy products, discontinue the drug once pain subsides. So I know D is not right because it's a chronic disorder. They take allopurinol to prevent problems. So you don't discontinue it once the pain subsides. Does vitamin C have anything to do with gout? It doesn't, that I know of. And dairy products don't have anything to do with gout that I know of. Why would I say B? Well, one of the ways you can get rid of the uric acid is to flush it out of your kidneys. And so that's just a really good intervention for someone with uric acid crystals settling. It also prevents you from getting uric acid stones. So this requires a little bit more clinical reasoning. It's not an absolute, like 100% sure I've got the right answer. So, I mean, I know is the right answer because I wrote the question, but here's what I'm saying. Clinical reasoning questions, when you get ready to answer them and you choose an answer, you're not going to feel 100% sure. Okay. You're not. You have to be ready for that. You have to be prepared that when you take your NCLEX, you're going to finish and it's going to, whatever number, 85, 105, 155, whatever number it shuts off at, you're not going to know if you pass. You're just not going to know. Because clinical reasoning questions, you just cannot be 100% certain of what the right answer is because there's no memorized answer. A lot of clinical reasoning involves ruling out wrong answers. Like I know D is wrong and I don't have any reason to think A and C have anything to do with gout, but increasing fluid intake, I can reason why that would be a good answer. And so I'm picking it. But you have to be ready that when you take your NCLEX, you're not going to be 100% sure of these answers. You have to learn the strategies to think through it, be confident in your answers, use the strategies I teach you, and then move on to the next question. You can't focus on the question you just answered. You can't worry that you got it wrong. You're going to get questions wrong. It's fine. You can still pass even if you get questions wrong. So don't focus on the question you just answered. Focus on the question you're answering now. Reason through it. Use strategies I'm teaching you, and you'll do fine. A postoperative total knee replacement patient reports a pain level of 8 out of 10 despite receiving scheduled opioids. Which action should the nurse take next? Administer the PRN dose of opioid now. Encourage use of continuous passive motion machine. Apply cold packs to the surgical site. Teach the patient relaxation techniques. All right, so we gave them opioids, so I'm not going to give them more. That just doesn't seem good to me. So I'm crossing off A. Is movement going to help? I don't think so. I mean, I'm not an orthopedic nurse, but it doesn't make sense to me that when they have a pain of 8 out of 10, that now I'm going to go, oh, let's move it. Like, that doesn't make sense to me. Apply cold packs to the surgical site. And you may say, well, we don't normally apply cold packs to the surgical site. That's true. We don't. However, orthopedic surgeries, we know that joint replacements tend to swell. And we know ice can reduce that. And I also know that a general acronym for musculoskeletal disorders is RICE, rest, ice, compression, elevation. And ice is a very common intervention for musculoskeletal injuries. Now, it's not an injury like we think of an injury, but it is an injury because we just cut into the joint. So that isn't an injury. It's an intentional injury, but it's still an injury. So it makes sense that we would use cold packs. Now, relaxation is a non-pharmacological strategy for pain. However, this is specific to an orthopedic injury, a surgery. We know swelling is a big problem after orthopedic surgeries, and we do want to get the swelling down, and you can numb it up a little bit. That's like an immediate relief. When you put ice on something, it's like an immediate relief. So you can numb it up a little bit. You already gave them the opioid. Give them a chance to get that swelling down, get some immediate numbness to relieve the pain, and then see what happens next. So the correct answer is C. A 10-year-old with Duchenne muscular dystrophy begins to have difficulty rising from a chair, positive Gower sign. The nurse anticipates teaching the family about use of ankle-foot orthosis, respiratory hygiene, and cough assistance, low protein, low calorie diet, non-steroidal anti-inflammatory drugs. Okay, so there's a lot here that you may not know much about. There's one thing you do have to know, and you have to know that muscular dystrophy is a chronic muscle weakening disorder. There's a lot more you can know about it, and you may know a lot more about it, but you don't have to pass NCLEX. You have to know it's a chronic muscle weakening disorder. So if they're having trouble rising from the chair, that means it's because of weakness. You may say, well, how do you know that? You don't know what a positive Gower sign is. I don't have to know what a positive Gower sign is. I know what muscular dystrophy is. And they're not going to give me some other symptom when it relates to chronic muscle weakness and muscle wasting. They're not going to give me some random symptom that has nothing to do with muscular dystrophy. If I'm using clinical reasoning, then I say it's got to have something to do with the muscle weakness. So what an orthosis is like a brace. Okay, that's all it is, an ankle foot brace. So if a 10-year-old child's having chronic muscle weakness and we can brace the foot and ankle, would that help? It makes sense that it would. Now, maybe there's a better answer, but it seems make sense that it would. Respiratory hygiene and cough assistance. That has nothing to do with muscle weakness. Low protein, low calorie diet. I would not think that would be good at all. We've got muscle weakness. I would think we'd want a higher protein diet. That just doesn't make any sense clinically to use common sense and clinical reasoning. Anti-inflammatory. It's not an inflammatory disorder. It's a muscle weakening, muscle wasting. So the correct answer is this ankle foot orthosis. And you don't have to know what Gower sign is. You don't have to know what Duchenne muscular dystrophy is. You just have to know what muscular dystrophy is. And you don't even have to know that much about it. A client on long-term corticosteroid therapy for polymyalgia rheumatica is at greatest risk for developing what? Osteoporosis, rheumatoid nodules, hyperkalemia, tendon hypertrophy. Now, it could be really tempting to say, I don't know anything about polymyalgia rheumatica. So if you don't know anything about it, you should do what I'm going to tell you to do, and that is you should ignore it. Now, it doesn't mean you completely ignore it, but turn it into something else. Long-term corticosteroid therapy for some kind of rheumatic disorder. Okay, some kind of rheumatic disorder. Muscle. It's polymyalgia. Myalgia is muscle. Okay, so it's a rheumatic muscle disorder. So I don't know that much about it. C and D, I've never heard of that having to do with a muscle rheumatic disorder. Like I just never heard of it. And unless nothing else makes sense, I'm not going to pick it. Rheumatoid nodules. I don't know. I don't know if they get rheumatoid nodules. Now, this is because I looked more closely at the words, I'm thinking muscle, right? Muscle rheumatica. Rheumatoid nodules has to do with joints, is a joint issue. And it doesn't look like we're talking joints here. It looks like we're talking muscles. So B, I don't know. Now, I might pick B if A made no sense, but A is specific to the corticosteroid, and they said long-term corticosteroid therapy. And I know osteoporosis is a very significant risk associated with long-term corticosteroid use. So if I'm going to use clinical reasoning and common sense, I'm going to focus on the corticosteroid that I do know about. I'm going to answer the question based on my knowledge about corticosteroid use, and not my ignorance about polymyalgia rheumatica. The nurse reviews morning lab results for a patient with suspected osteomyelitis. Osteo is bone, myelitis, usually inflammation, usually indicates an infection of the bone. Which lab finding best supports this diagnosis? Elevated alkaline phosphatase, decreased erythrocyte sedimentation rate, increased C-reactive protein, low rheumatoid factor. So ALK, I don't know if it's how it's abbreviated, ALK, AKP, I don't know, ALP, I don't know. But it's liver. And I don't know why the liver would be affected as relates to the bone. I mean, it could be, but like, I don't know that. So I like to answer questions based on my knowledge, not my ignorance. Decreased erythrocyte sedimentation rate. I don't know why it would affect the erythrocyte, decrease the erythrocyte sedimentation rate. Increase C-reactive protein. Now, I don't know much about CRP, but I know it's an inflammatory marker, and itis means inflammation. So if I'm going to answer based on my knowledge and not my ignorance, I'm going to pick something that indicates an inflammation. So increased C-reactive protein makes sense. Low rheumatoid factor. I don't know why a rheumatoid factor would have anything to do with osteomyelitis. So I'm going to pick what I know is an inflammatory marker, and I'm going to get it right. And I don't have to go and learn all kinds of stuff about osteomyelitis or C-reactive protein. I don't have to learn a bunch of stuff about alkaline phosphatase. I don't have to learn a bunch of stuff about erythrocyte sedimentation rate, because I'm going to use clinical reasoning and common sense, clinical reasoning a lot here to answer this question. Remember, we answer questions based on our knowledge, not our ignorance. Some of you, perhaps, I've never gotten a comment really like this, but some of you may wonder why I don't do more teaching about the questions, like why I don't teach you everything about all the answers. The reason I don't do that is because you don't have to know it. You cannot know everything. You have to know how to use clinical reasoning to answer questions on the NCLEX in order to pass. A 16-year-old with a sports-related anterior cruciate ligament tear, ACL, is in a long leg brace. Which instruction should the nurse reinforce? Use ice for 20 minutes every 2 hours. Bear weight on the affected leg as tolerated. Keep the knee in slight flexion at all times. Avoid quadriceps strengthening until healed. Quadriceps. I don't know why you'd have to avoid quadriceps strengthening. You could just do like contraction of your quads. Just like contract it, relax it, contract it, relax it. That's not going to hurt anything. So D doesn't make sense to me. So we'll cross that off. All right. So, I mean, if you've had an ACL tear, maybe you know the answer to this, but let's say you haven't. I've never had one, and I'm not an orthopedic nurse or musculoskeletal nurse. I'm cardiac mostly is my area of expertise. So I say, I don't know that much about it, but here's something I know about musculoskeletal injuries. I know RICE, rest, ice, compression, elevation. So if I'm going to answer this based on what I know, my knowledge, and not my ignorance, I'm going to pick A because that's ice. B, bearing weight, that's not rest, right? I'm looking for rest. Keep the knee in slight flexion. Flexion is slightly bent. It doesn't say elevation. It doesn't say compression, and they're in a brace. So the fact that it's in a brace kind of makes me wonder if they even can flex it. Most braces keep things extended usually. So the only one that makes any sense to me is the ice answer. So I'm going to pick it and we're going to move on. And I'm not going to go back and try to learn everything I can about ACL repair. Select the assessment finding that indicate compartment syndrome in a patient with below the knee cast. Severe pain unrelieved by analgesics, pallor of the toes, diminished pedal pulses, paresthesia of the foot, or slight edema under the cast. So I want to, this isn't common sense or clinical reasoning. This is the 5 or 6 Ps associated with compartment syndrome. Okay, so this is just facts. So you have 5 or 6 Ps. It's 6, but sometimes you forget the 6th one. So you have pain, paresthesia, which is loss of sensation, paralysis, which is loss of movement, pulselessness, pallor, and then the 6th one that I often forget is poikilothermia, which is low temperature. So it starts to get cool. So when you get a question like this, you should always think, what in general do I know? So compartment syndrome, pain. Okay. A is pain. B is pallor. C is pedal pulses. D is paresthesia. Now, slight edema under the cast. Now, compartment syndrome is severe swelling. So, yeah, I'm not thinking slight edema. Like, slight edema isn't compartment syndrome. You're looking at massive edema to the point that it cuts off circulation. That's what you're looking for, not slight edema. A patient with osteoporosis is prescribed calcium and vitamin D supplements. The nurse should instruct them to take them with meals. Oh, this is a SATA question. At bedtime with a full glass of water, along with antacids or separate from iron supplements. So remember, when you get SATA questions, it's not about did you memorize a list. Okay, that's not what it's asking you. So here I might say, I don't know much about taking calcium and vitamin D. Like, I don't know much about it. So let's say, what do we know? What do we know? Instead of our ignorance, should we take it with meals? Well, we have two options. We have with meals or at bedtime. They cannot both be right. They can't be. And if you have opposites, particularly in a SATA question, one of them's got to be right. So would I rather them take it with meals, or would I rather them take it at bedtime? And I just think, if I just use clinical reasoning and common sense, I say, when are most meds taken? Most meds are not taken at bedtime or at HS. In fact, and this isn't always a good way to answer the question, but I've never given calcium and vitamin D at bedtime, ever. And so that just doesn't make sense. And so and I do tell them to take a lot of things with meals, just because there's decreases GI problems. Some things it's better absorbed with meals. Now, calcium and vitamin D do happen to be better absorbed with meals, but you don't have to know that to get this right. Okay. So I'm going to pick A, not B, with a full glass of water. Y'all, I don't know why I remember this, but I always remember you're supposed to take calcium and vitamin D with a full glass of water. And I can't even remember why. It has something, I think it has something to do with absorption or something. I don't know what it is, but I know you're supposed to take it with a full glass of water. So that's good. Along with antacids. Y'all never, never, never take any other meds with antacids. Absolutely not. Decreases absorption. Absolutely not. Separate from iron supplements. So you never, never, never take meds with iron or antacids. Okay. It has some issues with absorption. So it says, this one says separate from iron supplements. So I like that. See, D is not good because it says along with antacids, but E is separate from iron supplements. So I like that. So I like with meals with a full glass of water and separate from iron supplements. So these may be principles. They're testing principles. Do you understand some of these things? Do you have to memorize this list? Well, no, because you never take anything. It's not about calcium and vitamin D. You never take anything, other meds with iron. You never take any meds with antacids. So those are general principles. The only one here that's really specific to calcium and vitamin D is full glass of water. A client with rheumatoid arthritis is being discharged on prednisone. Teach the patient to monitor for what? All right. So is this about rheumatoid arthritis or about prednisone? Let's look. Hyperglycemia, weight gain, increased susceptibility to infections, bradycardia, or mood swings. So this is obviously about prednisone because none of those are rheumatoid arthritis symptoms. So Clinic Reviews does teach about Cushing's syndrome. One of the reasons I've never taught about Cushing's here on the channel is because that's taught as part of the big 21 plus hour Clinic Review. And he teaches about it using a drawing that he calls Cushman. So if you want to learn, if you've heard about Cushman, you want to learn about Cushman, you can take the 21-hour Clinic Review. So I'm just going to tell you what the right answers are here. And you should, honestly, these aren't that hard. You probably know hyperglycemia. Everybody knows that. Weight gain, you should know that. I think most people know that. Increased susceptibility to infections. I do think most people know that. Prednisone is an immunosuppressant. It's a mild immunosuppressant, but it's still an immunosuppressant. Bradycardia has nothing to do with that. And mood swings. That may be the one you're not familiar with. It's called emotional lability, means mood swings up and down. Emotional lability is also associated with drunkenness. If you ever talk to someone who's drunk and like 1 minute they hate you and 1 minute they love you, right? I love you. You're my best friend. Why do you hate me so much? Why do you treat me this way? Right? Like that's emotional lability. Okay. So that's actually also associated with long-term prednisone use. When caring for a client in Buck's traction, which nursing interventions are essential? Ensure weights hang freely, reposition the client every 2 hours, monitor skin integrity at the heel, perform active foot and ankle exercises, massage the muscle at the traction site. So this isn't so much about clinical reasoning. You shouldn't have to memorize this list, but you do have to know what Buck's traction is. So Buck's is traction is sort of the opposite of skeletal traction. Skeletal traction puts tension on a muscle to get it back into alignment, and it also kind of can physically realign things, whereas Buck's traction uses weight to realign bones. It's often used like if they have to wait for surgery. So if they had a pretty big, say, femur fracture on a Saturday night and they can't go to surgery until Monday, they may put them in Buck's traction over the weekend. It's realigning using weight, and it's really just it's not a cast, but it's like a wrap around the ankle, foot, and lower extremity that then you hang a weight off. And I think the weight is no more than like 5 pounds, but they can't really, I mean, they're not like exercising that leg. Okay. So they got to kind of let it align. So does the weight hang freely? Well, yes. If it doesn't hang freely, then it can't pull on that leg like it's supposed to. Reposition the client every 2 hours. Y'all, we always reposition the client every 2 hours. This isn't specific to Buck's traction. Everybody gets repositioned every 2 hours. And don't say to me, well, how do I do that? They have a weight. That's not what the question is asking you. I will admit it's not easy. Okay. But we still have to do it. Okay. You can turn them on their side. You can put a pillow between their legs. They don't bend their knee, right? You got to work a little bit to get them comfortable, but you still have to reposition them. Everybody gets that. Monitor skin integrity at the heel, or that's where that kind of boot wrap ends up going. So yes, perform active foot and ankle exercises. So if it's a femur fracture, you can move their foot and ankle because you don't want them to get a DVT in the middle of all this, right? So they can't get up and walk, but you don't, I mean, I'm sure they'll be on something to prevent DVT, but you still don't want them to get that. So do some little ankle exercises. Massage the muscle at the traction site. No, I don't even know what that means, because the traction site is like around their foot and ankle, and you're not going to massage anything there. Which signs and symptoms are associated with osteomyelitis? So osteomyelitis is an inflammation/infection of the bone. Fever and chills, swelling and erythema at the site, decreased sedimentation rate, night pain unrelieved by rest, purulent drainage from the wound. So you don't have to know that much about osteomyelitis. You say, if they have an infection, what's that going to look like? Well, A, it's going to look like fever and chills. If they have inflammation, they're going to have swelling and erythema at the site. A and B is just clinical reasoning and common sense. Decreased sedimentation rate. Y'all, do not answer based on your ignorance rather than your knowledge. Do you know decreased sedimentation rate is associated with infection, inflammation? I don't know that. I doubt you know that. So we're not going to pick C. Night pain unrelieved by rest. So that is one of the things about this bone infection/inflammation, is that resting doesn't give them any relief from that. So they're often awoken. Like bone pain is, from what I've heard, is a pretty severe pain. And it can, wake them up or prevent them from sleeping. So that is associated with that infection, inflammation of the bone. Purulent drainage from the wound. Yeah, I mean, not always, but often that's the case. So purulent drainage is associated with infection. So we've got an infection of the bone. So use your clinical reasoning and say, what is associated with infection? So I told you this one was going to be, I told you the last video, I told you this video was going to be shorter. And I usually don't keep to my word on that. Usually I just keep writing questions like, this is a good question, but this is a good question. I just keep going. This time I'm like, no, I'm going to stop. And it's still 30 minutes, at least on my time clock. So I hope you have a great rest of your day. Get some rest. Get some rest the day before you take your NCLEX. Don't be studying right up until the very second you have to go. Okay. You gotta get some rest. Have somebody on standby you can call in case you get a flat tire or something. And don't expect to know every answer. You get a question, you don't know the answer, you go, oh, that's okay. I knew I wasn't going to know the answer. I'm going to use clinical reasoning and common sense to answer this because I know I can. All right. Good luck on your NCLEX. Take care. Thanks for being a part of our Clinic Review family.